Good morning. This discussion is going to cover information from Chapter 55, which addresses urinary disorders. In particular, we're going to focus on urinary disorders of the female genitourinary. Therefore, it's collectively included in this course as we classify review of systems as genitourinary. It would be considered any disorder of the genital or reproductive tract of the female. So you will note that this chapter is highly dissected according to your course that you're taking in our current curriculum, and that is that there are a number of pages and information that are covered in your previous semester in your basic med surg that addressed issues like basic renal assessment, catheterization. This is information that you've already received in the lab setting. The readings that were assigned for your lab in med surg correspond to those pages that are found in this chapter, and I'll kind of just briefly skim over those as I feel confident that you have that information. And likewise, there's some information about the renal cancers, in particular the bladder cancer patient. And again, cancers are not covered in this discussion, and many of your cancers will be covered next semester in your complex medical surgical patient, where we break systems down and talk about those more advanced disease processes. So let's move forward and just sort of a gentle review of the urinary system, which you've had multiple times between A and P and med surg. But whenever we're addressing the urinary system, we want to pay close attention to a thorough assessment that would include taking any kind of history, medical history, anything that we could identify as a potential impact on function of urinary system. So of course that would be any kind of history of any bladder issues, urethral issues, anatomy issues, and then some disease as well. Obviously renal disease would be huge, but even things like diabetes, because we know that there can be issues of infection with this population. Any recent changes, so changes in their urinary patterns, how they void, frequency of voiding, characteristics of voiding, and characteristics of their even changes in their urine if they're noticing anything different in their own home setting. We would then move on to our physical assessment, which includes inspection first. So we're going to inspect the abdomen, and whenever you're doing a urinary system assessment, we're inspecting the urine. That's a really important part, right? It leaves the body, but we want to look at that, note color, note clarity, or concentration perhaps, any foul odor. That's all included in our assessment of the urinary system. We then move to palpation, and when we talk about palpation, in particular when we're talking about UTIs or the bladder, sometimes folks will present with some suprapubic pain, or even that assessment when we look for costovertebral angle or CVA assessment, we can assess for that very blunt flank pain that can exist in the flanks. We then move on to reviewing the results of the diagnostic workup, and that might include a urinalysis, which is typically a random clean catch, or a culture and sensitivity, that's your CNS, which we want to pay close attention to in the NCLEX world. A culture and sensitivity is best assessed under sterile catheterization because we have made the best attempt to eliminate any pathogens. We are going to assess things like specific gravity. We may have results from imaging, and imaging can be a wide variety of methodologies used, like a KUB, which is a kidney, urethra, bladder. That's a flat panel x-ray of the lower part of the abdomen. Ultrasound, CAT scans, MRIs, retrograde pylography. We're looking at maybe an IVP, where they're using intravenous dyes to watch how urine moves through the kidney, or some lower baseline examination that physicians may perform would be a cystoscopy. So a cystoscopy is a scope into the bladder. So it's inserted at the urethra, up into the bladder, and the physician can do some visual inspection. And then finally, biopsy. And whenever we're using a scope, the ability to obtain tissue to be examined by pathology and histology in a lab setting. So when we look at this chapter, the couple places we want to pay close attention to in particular is UTIs. And urinary tract infections are classified or broken down into two categories, and that's either a lower or an upper. A great example of a lower UTI is a cystitis. So we have a inflamed bladder, secondary typically to some sort of pathogen like bacteria that's gotten into the urinary tract. We cover this a little bit more in depth in the female course because females are at a significantly higher rate or risk of developing UTIs just because of basic anatomy, and that the urethral opening and the distance between the urethra, the meatus, and the bladder is significantly shorter than that of our male counterpart. The upper UTIs we're talking about things like pyelonephritis or the development of some sort of a renal abscess, but these are the infections that are taking place that are well above the bladder. So we're moving up through the ureter into the actual kidney. Pathophysiology for these infections, bacteria, exclamation bacteria, because that's exactly what it is. It's when bacteria has entered the area for a number of reasons. And you'll see that on my slide, I have location, or function. So, again, anatomy gives that woman a higher risk of developing a UTI because of the close proximity of the meatus. The most common bacteria that is found in UTIs is E. coli. And, there's close proximity in the perineum between the meatus and the anus. So therein right off is a great risk factor. But then it also could be function. So it can be reflux, where the woman is experiencing reflux of urine, which kind of dips down close to, and your textbook gives you a nice pictorial depiction of the 4 different types of reflux that occur. It gives you a nice visual and to see how bacteria can really swarm the area in cases of reflux. Signs and symptoms of a UTI, and this is really important to take away, not just for an exam, but in clinical practice as a nurse. 50%, up to 50% of individuals, females, with a UTI will have no symptoms whatsoever. Very, very subtle. Like it's not obvious to them, which then leaves this population at risk for the infection to develop further up into the renal system, which can then become a pyelonephritis. Typically, we'll talk about pyelonephritis in a few minutes, but typically when pyelonephritis sets in, right now we have bacteria up in the renals, then the symptoms become pretty clear. But when we're talking about those lower UTIs, again, up to 50% have no symptoms. For those women who do experience symptoms, you might be seeing things like dysuria, painful, uncomfortable, voiding, nocturia. She might report she's up a lot, frequency in the bathroom, feels like she's not emptying, or has spasms. Some women will describe it as a spasm, pelvic or pubic discomfort, just like it's sore to touch. And the geriatric patient, pay close attention. I'm sure you've already heard this in your nursing education, but oftentimes they will present with confusion and again, very subtle symptoms before this, and now they are presenting with lethargy, anorexia, and again, they could even show signs of shock because they can go septic, right? Any patient can from UTI. The flank pain and the abdominal pain, nausea, vomiting, typically are associated with a higher or upper UTI. And then the febrility of the patient. Some patients will present with a fever, many will not with a UTI. And again, oftentimes we'll see an altered urinalysis. So we'll see those white and red blood cells in the dipstick if we're doing a random. So who's at risk for developing a UTI? Well, right off the bat, we already know females, right? Because of anatomy and proximity to E. coli. But any woman who's had a history of frequent UTIs, we should always be surveying for those subtle signs and symptoms. And typically women know this, but not all, and that they've had repetitive UTIs, they're at risk. And then you'll see right there, pregnancy, postmenopausal women, that's why we're talking about it here in our third semester, and addressing it when we talk about the female lifespan. Pregnancy definitely increases, and again, that's that decreased capacity of the bladder, increased congestion of the perineum. All of those things puts the pregnant woman at risk for developing a higher risk for developing a UTI. Postmenopausal women, we haven't talked about menopause yet, but one of the things that happens in menopause is decreased production of many of the secretory glands in the vaginal tract, there and around the perineum, and that dryness, if you will, leaves the woman to open to less natural protection and also breaks in skin. So she's at greater risk too for UTI. Anytime a woman has a new sex partner or any invasive procedures such as your catheterization or cystoscope or something to that effect. How do we treat, that's your RX, how do we treat UTIs for our patients? Frontline is pharmacological management, and the drugs of choice in your textbook again has a beautiful graph that breaks down each drug classification and how it's used and the unique things you should know about those drugs. But for classifications, we're seeing clinically in the clinical setting today, cephalosporins, antibiotics, sulfonamides, and your levofloxacin is also a common treatment for UTIs. So again, that UTI that's not managed or treated can then move forward to become a pyelonephritis. When we look at pyelonephritis, and this is infection of that upper urinary system up into the kidney, we're going to usually classify it as an acute episode. So never had one before, a UTI that wasn't detected or managed, and now is this acute pyelonephritis, or is this the chronic pyelonephritis? This is the woman or individual who develops pyelonephritis over a long span of time. Usually with pyelonephritis, we have far more intense or acute signs and symptoms. These folks feel sick. They just don't feel good because they're likely developing those systemic responses to infection, like a fever and chills and nausea and vomiting, and they often will complain of back pain, and they just feel lousy, anorexic, they're not hungry. Please keep in mind that chronic pyelonephritis, if not managed well, can lead to renal failure, and acute chronic renal failure, in some cases, if not caught, can be a cause of death. So it's serious to pay attention to these clients. Diagnostics for pyelonephritis continue to be similar to the lower UTIs. We're going to be paying close attention to their urine studies. We're going to be likely seeing lots of more advanced diagnostics like ultrasound and CAT scans to take a look at those kidneys. Keep in mind that pyelonephritis, the fluids could be increased as high as 3 to 4 liters. And notice I put there in parentheses, anytime we're going to move up to 3 liters of fluid per day in any patient would require in-depth assessment before we administer that. Can they tolerate that high level of volume? So of course, I know you're all thinking, cardiac patient, what is their renal function? Can they manage this increased load? So that always comes with consideration. Before I'm going to end it here to go into part 2, we're going to move into nursing care and just some of those prescriptive things. I'll see you on the next side.